I'm I am Dr. Caroline Wynn, and my co-chair, Dr. Carl Driscoll, is not here tonight. We would like to welcome you back to our virtual speaker series meant to replace our annual session. A little housekeeping note first. Questions will be answered at the end of the presentation. Please do not use the chat to ask questions, but rather use the Q&A area. The button to access the Q&A should be at the bottom center of your screen. The panelists will read your questions and ask them on your behalf to the presenter at the end of the session, if time permits. Our speaker today is one of my dear friend and colleague from Vancouver, Canada. Dr. David Yang went to dental school at the University of Toronto, followed by a GPR program at Cornell Medical Center. He then completed his specialist oral and maxillofacial surgery training program at Cornell Medical Center as well. He is a clinical assistant professor at the University of British Columbia and is the provincial practice leader in oral and maxillofacial surgery for BC Cancer. He is a member and a speaker for numerous dental societies, both in Canada and the US. His presentation today is on surgical options for prosthodontics rehabilitation. Please welcome Dr. David Yang.
Thank you, Caroline, for the very, very generous introduction. It is really a pleasure to be here. I count myself amongst the very lucky within my oral surgery colleagues because I have the privilege of leaning on my prosthodontic colleagues very heavily in pretty much all aspects of my practice. So in the hospital, in the BC Cancer, working alongside Caroline, Dr. Nguyen, the maxillofacial prosthodontist, I certainly learned a lot about oral reconstruction. And whether it's community or study clubs, there's always a prosthodontist helping me out on the most challenging cases. And last but certainly not least, I happen to be married to a prosthodontist. So she's both my biggest critic and also my most devoted mentor. So it really is a privilege to be here speaking to this prosthodontic group, and I thank you. I have no conflicts of interest to declare. And lecture objectives, I find at the time that we submit these a year ahead, they're always very, very verbose. I think I'm a very direct guy. I feel like if we really boil down what we're here to talk about today, I would say we're here to talk a bit about clinical, a bit about business, practice management. On the clinical side, where we'll start, I think treatment longevity is something we would all love to have. There's the excitement that comes from executing a complicated case well. And then there's that dreaded sort of waiting period for if and when something is going to have a complication years later. So I guess we'll start off with a hypothetical scenario. Let's say that these are husband and wife, right? And I realize no x-rays, no models, no exam for you guys to answer this question. But let's just say, okay, let's say the upper arch is perfect. Let's say that the lower arch for both husband and wife are terminal. And they came in specifically seeking a same day all-on-4 with immediate load. Would you guys offer this to one or both or neither spouses? So that's a question to put in your brain for a little bit. I think if we boil down all-on-4s down to their naked components, I would say that they're characterized by apically positioned implant platforms with a tall superstructure, and they tend to have either tilted or at least non-axial implants. And this first two items, the apically positioned platforms and a tall superstructure, it really is a very key part of their longevity. Because whether we're talking about all-on-4 design, where classically as much as 15 millimeters of space is needed, or a trefoil, where it's about 22 millimeters, it's not an insignificant amount of reduction. This is a bone reduction guide that we had used in the past for a trefoil case, I believe. And that would be quite an amount of reduction that we're doing. And to look at it from a different point of view, this isn't my slide. This isn't how I do my alveolectomies. But it really illustrates the fact that I hope you guys can all see your cursor, my cursor here. If you cannot, do let me know. Here we are. We have patients that are unable to maintain hygiene at this level. And we're asking them now, the same person, to now maintain hygiene at this level with a splinter restoration, no less. Right. So let's think about how that could impact our longevity and how we could best plan around that. So we'll start off with a couple cases. I want to share with you some cases through a slightly different lens. I'm going to start with the oral oncology viewpoint, and just bear with me as we go through these, and I promise to come back at the end to connect it to our current topic. So this is Jenny, who has a destructive lesion of her right maxilla, ultimately needing the amputation of her right maxilla. She was reconstructed with a free flap, a segment of her right fibula, along with the overlying skin. So even though this was a good 10 years ago now, with the technology available at that time, it was a very routine workflow with the analog wax up overlaid to the digital scan, allowing us to plan a restoratively driven implant positions and then execute using a CAD/CAM stent workflow. And here's the resulting product, right? This is the resulting position of the implants that roughly mimic the plan that we had set up digitally. And how I may characterize this restoration for Jenny would be that she has apically positioned implant platform. She has a tall superstructure, and she has a tilted or at least non-axial implant placements. And if that's ringing a bell, that's by design, because earlier we were mentioning this being all on four. So even though they may look slightly different and how they got there may be a little different, I find this patient population really shares a lot of the characteristics of our typical all-on-four reconstructions. So if we look at another free flap reconstruction patient, this happens to be Min. Min is a 58-year-old gentleman who unfortunately lost a portion of his mandible to a large benign tumor. And he was reconstructed in a cancer-like fashion with a fibula segment from his leg. So once the bone of the leg here has fused to the jaw here and here, the metal plate can be removed, and then Min can go on to have routine dental implant placement and routine dental reconstruction, in this case restored with a fixed hybrid design. Right, so angulations and implant positions being a little different, in many ways, this design is not all that different from a typical all-on-four hybrid that we might do. So 6 years after initial treatment success of 2014, in sometime last year in the middle of COVID, Min came back with what looked like end-stage peri-implantitis of the midline implant. Now, these photos are shared with me by his community periodontist. I think the periodontist has very valiantly fought this battle with peri-implantitis on many of his other implants. As you can see, none of these implants really have any attached tissue wrap around them. But this one implant in the middle just seems to be particularly stubborn, despite his best efforts. The progressive soft tissue inflammation on the surface, coupled with the progressive cupping bone loss around this implant, worried the periodontist to the point where we became involved in his care. So we took a look at Min for the very first time at that point, and what we saw was that on cone beam, the fibula strut only had about 2.5 millimeters of bone thickness, whereas the rest has all been lost due to bone loss. So Min is now faced with two very poor choices, right? Choice number one, we can choose to stay conservative like we have been with the periodontist, but it's believed that his disease will progress, and then that 2.5 millimeter will eventually fracture, leading to a broken jaw. Or we could go ahead and remove the implant. That's probably the best way to arrest the localized peri-implantitis. But then the question becomes, here we have an implant that's osseointegrated to both thin struts of the bone. How would one go about removing that implant without iatrogenically fracturing the jawbone, in the process? So very luckily for Min, he had a happy ending, leaning very heavily on our prosthodontic colleagues. I think Min was able to achieve a successful outcome with actually full regeneration of the bone defect without a fracture. But if you are interested in the management, then I'll direct you to this reference because it's not really in the context of our talk today. But Min happened to have a very fixable situation. Not all cases are as easy to fix. This is Jenny, whom we met earlier. She had her 6 implants placed. She ended up having a conus restoration. And at first, there was initial treatment success, So here is here are the photos of how she ended up later on. These photos are taken now 6 years after treatment. And comparing the white line, which would have been roughly where her tissue level would have been at the time of restoration, and the red line here, which are where her current tissue levels are, we're measuring roughly a 6 millimeter deficit. Now, in the mouth, the tissue follows bone, so a 6 millimeter recession of the gum typically means at least a 6 millimeter loss of the bone height. And that is significant, particularly in the fibula, because the fibula start to finish is only about 11 to 12 millimeters tall. So to lose 6 millimeters of that bone in the first 6 years of the treatment does not bode well for long-term success. Jenny happens to be a very young individual in her early 30s currently. So unfortunately, it's very likely that she will not experience a lifetime success with her restoration. So looking at the bone levels here, the shortcut that we took to regenerate that gentleman's jaw earlier in Min's case simply cannot be applied in Jenny's more generalized, more rampant case. So learning from how these reconstructions fail, perhaps there will be some gems that we can then take into our practice and try to prevent similar outcomes for our all-on-4 patients. If we look at where these free flap reconstructions tend to fail, they do show a certain pattern. Failure at the implant themselves are rare. I think we'd all agree modern implants rarely fracture, and when they do fracture, is usually a symptom of a more serious underlying issue. Restoration definitely can fail, and I understand that from a prosthodontic definition, that would be treatment failure. But I think for the medical colleague, they would look like that and say, if metal and plastic is broken and you can put in new metal and plastic and make the patient whole again, then medically that wouldn't be considered a failure. That would just be called maintenance. I think the truly devastating failures are the ones that happen in the hard and soft tissue interface, because those are often irreversible. So let's look at why that happens to be the pattern of failure. So let's go on a hypothetical situation here. Let's say that you and I, the people in this chat, happen to be the first group of dentists ever wacky enough to contemplate this type of treatment, right? We're the first ones to ever think about putting implants into bone and having it stick out into the oral environment in some capacity. If we were to want to look to our medical colleagues for advice, I think the closest to that kind of practice would be our orthopedic surgeons, who perform external fixations that look, you know, if you'll pardon me, it looks a lot like a fixed bridge, right? So these metal pins are rather emerging, they're drilled through the bone, but they do perforate out of the soft tissue, and they're then splinted together via some kind of a superstructure. So if you talk to the orthopedic surgeon, what they would tell you is that wound care here has to be meticulous because infection rate is very high. This dressing that is wrapped around the leg is a pressure dressing. The goal of that pressure dressing is, if this is the implant and if this is the skin, the goal is to wrap that skin tightly around the implant and not allow any movement, because they are aware that any movement of this tissue opens up a gap peri-implant. That could then be a new wound and new bacteria entrance. So there's the pressure dressing. There's the fact that these wounds are kept very dry. Moisture is bad because moisture means bacteria and fungus. There's the fact that they leave these in for as short time frame as possible. They try to take them out within weeks to months because invariably infection will always catch up to these wounds. So if we said to the orthopedic surgeon, well, that's all very interesting, but we're going to do something a little different. There's no pressure dressing. We're going to allow the lip and the tongue to animate freely around these implants, which they certainly do. We are going to have these implants coming out through maybe skin, maybe unattached tissue in a very wet environment, and not just water. We're talking saliva, contaminants, food, and 24/7. And we're also going to leave these in really for the rest of the patient's lives. I think the orthopedic surgeon will be a bit perplexed by our goals. And that's really what we do, right? We place these implants in the leg, and if the skin is very, very thick, we'll thin out the skin and we'll sew it, so we wrap it around the implants. Sometimes we take a shortcut and we just poke a hole with a hole punch, but sometimes if you do that without thinning out the underlying tissue, it just ends up overgrowing a couple of weeks later, which we don't want. And there's many different ways that this workflow can be done. This would be an example of a very conservative approach. Here, the implants are placed secondarily after the fibula has fused to the jaw. The implants are placed in a two-stage fashion where we lift up this really thick skin paddle, place the implants, throw the skin back down, allow integration. And then 4 months later, come back for stage 2, right? We go back and we fillet out this tissue so it becomes a very thin strip of skin tissue. So look at the thickness of the original skin and look at how thin the skin is now. We go ahead and punch some holes that are corresponding, and we have the healing abutments poke out of the holes like little chimneys. So we can try to reproduce a gum-like thickness with skin, but what we cannot reproduce is gum-like behavior, because thin skin doesn't automatically mean attached skin. I think if you feel the skin by your eye socket on the side of the eye, for example, that is probably one of the thinnest skin area in our body, but it is also notable just how movable that tissue is, how unattached that tissue is. And with that soft tissue unattachment comes a concern of opening up of the wound, right? This is exactly what the orthopedic surgeons do not want with motion, because any motion creates this opening where bacteria and contaminants can enter the wound and enter the bone. So this gentleman here, despite giving him a very cleansable scheme of only healing abutments, despite having no restoration on it and giving him all the tools for oral hygiene, he unfortunately presented 3 separate visits with these chronic inflammation balls that we just cannot remedy. And this is in a cleansable situation. Imagine what it's like to have a splinter restoration that is fixed, right? Sometimes under the restorations, we don't see the inflammation balls, but once you take it off, you'll see these balls kind of wrap around the shape of the attachment. You can see this cupping-like effect, which cups around whatever attachment was connected to these abutments. Sometimes they're hidden under the flange of the restorations, and once you take off the restoration, you uncover the sort of mess that is underneath. So I think that if you show these x-rays to show these pictures to an orthopedic surgeon, I think their honest opinion would be that, I think they would say, why are you doing this? They would say to you, listen, if I did what you guys did, if I subjected these pins to the oral environment and the conditions that you mentioned earlier for a lifetime, I mean, I can tell you what's going to happen. I don't need to do that experiment. What's going to happen is that I'm going to have perimetal inflammation, these zones of inflammation where the bone will eventually soften and the pins will mobilize and pull out. That's internal. On the external, we will see a very robust soft tissue reaction. So this wouldn't be a good idea. And then we might say to them, well, it's interesting that you mentioned that, because that's sort of what we get, right? Not on all implants, but on enough implants for it to matter to the patient outcome. I think all of us who are in the business of putting patients in these all-on-4 or otherwise full-arch splinted implant restorations, we all know that the party line is to say, well, listen, your oral hygiene has to be meticulous. You got a water pick, you got a floss thread, you got to see your dentist, you got to do all this. You have to have a meticulous oral hygiene. And it's true that in the setting of meticulous oral hygiene, some patients go on to have a symptom-free existence. And sometimes, whether they do have oral hygiene practice or they do not, sometimes without that little bit of luck, they can have very exuberant inflammatory reactions around these deeply uncleansable implants, right? And I think we in the business of implant dentistry, we're all very clear on why this happened. We're all very clear that the absence of attached tissue, combined with other systemic host factors, are what gets us into this kind of a mess. So when we're talking about this topic to our medical colleagues, we had to boil it down into very, very, very nuts and bolts dentistry. We were talking to them about how the best replacement for gum tissue really is gum tissue. We might explain to our medical colleagues the importance of having this attached tissue band and why in the world of fibula and cancer treatment, this is never a resource we have. Just by nature of the resective surgeries, this gingiva that is so precious for peri-implant tissue is almost always sacrificed with the surgical specimen, right? So in the fibula world, we don't have the option of maintaining the patient's current, pre-existing gingiva. And the closest thing we could do is we could do a gum graft, right? So we're wondering what a gum graft would look like on the leg. So we went ahead and tried some, and it turns out a gum graft on the leg looks exactly like a gum graft on the jaw. So this is a fibula segment with just a very plain Jane free gingival graft. And what we see is both where the surgery was adequate in creating a peri-implant band of attached tissue. We saw very healthy tissue response compared to some of the train wrecks that I showed you earlier. But we also saw where our surgery sort of came up short, where we didn't plan for adequate tissue, attached tissue, we just ran out of tissue at this point. Just one little zone of the implant being in contact with the unattached flora of mouth tissue has immediate response, immediate inflammatory response at both sites. Right now, this has nothing to do with the fact that it's a free flap. There is no skin remaining here. The skin has been excised. This metal touching this flora of mouth tissue in the fibula patient really is no different than the metal touching the tongue tissue of a all-on-4 patient in all of our practices. So I think this is the cautionary tale that applies to all of us. And similarly, this is a different patient. It's an upper jaw, it's a scapula, but the very exuberant tissue reaction can be successfully mitigated just by converting this unattached tissue to a regular gum graft, despite the fact that the implants are placed in the shoulder blade, in the scapula. So looking at the tissue types, I think that if we know that this is our goal, if all of us would always want our implant and our peri-implant tissue to behave in this fashion, then I think that all of us want to achieve a peri-implant soft tissue scheme that looks something like this, with a zone of attached tissue on either side. If you have a vestibule, that's great. The vestibule is not a critical game changer, but having that zone of attached tissue, I think, is a big difference between success and long-term trouble. So here's just a full arch case where you can see the dramatic difference a couple millimeters of peri-implant tissue makes, right? Between somewhere where there is abundant attached tissue and somewhere where there isn't. So looking at learning the lessons from our oral oncology cases, what we realize here is that having this skin is just as bad as having some unattached buccal or floor of mouth tissue because of the zone of inflammation that occurs. And what we see on the 3D reconstruction or 3D imaging is that the skin is actually very thick. So this sloping here is very common, not just in our cancer-based cases, but actually very common all-on-4 cases where if there is no zone of attached gingiva facial to our all-on-4 implants, what ends up happening is that the buccal tissue will go ahead and go through the interproximals and will go ahead and attach to maybe some lingual KT or maybe to the lingual flora of mouth tissue and a muscle attachment. And you end up having this slope, which I'll show you in the upcoming slide. So this is a lady who had a very capable reconstruction of her jaw defect in a different center in Canada, not with us. And it's absolutely beautiful work. And she is following up with us a little bit because of COVID. And what we see is this indentation and inflammation of the lip wrapping around the componentry and the restoration because there is no attached tissue, because this tissue is attached, but it's attached all the way through the restoration to that lingual tissue, which has the effect of compressing the buccal tissue up against the restoration, and there will be irritation throughout function. So the remedy to all of our cancer agency patient woes have been the placement of gum graft over the leg or over the shoulder blade, and to show just a couple of cases of what the difference that would make. So this is a gentleman who had a fibula flap. So these are implants that are placed into the leg bone, and this is secondarily placed gum grafting around the implant. You can see this recreation of a pseudo vestibule, maybe at best a land area. But you can also see that because the peri-implant tissue is now stable, we're less worried about peri-implant infection and peri-implant inflammation. This is just a different gentleman with a maxillary situation. So what we learned is that, yes, excellent oral hygiene is great, but in the real world, not all of our patients are going to change their ways and give us that oral hygiene practice that we need. And if we can take that variable away, meaning that we can do gum grafting such that reliance on patient oral hygiene is removed, then I think that's great, right? If we have a treatment modality, whether we're talking about free fibula implantation or we're talking about all-on-4 elective implant surgery in our everyday patients, if we have a patient whose success solely hinges on the patient's ability to have not just decent, but exceptional oral hygiene, then I think that is a treatment modality that doesn't carry as much predictability as we would like. So for those colleagues in the audience that are a little bit more surgically attuned or interested, we'll do a very 30-second discussion of this technique. It's actually very simple. All it is that we excise a skin paddle. We harvest a piece of gum from the palate. We poke some holes. We'll go ahead and push that down around some kind of a retentive element. When I have the blessings of a maxillofacial colleague maxillofacial prosthodontic colleague working with me, which I dearly miss after Caroline changed her plans, then we may have the ability to have a splinted restoration, temporary restoration, without that shoulder looking over me. The best I can probably do as an oral surgeon is just some kind of bulky impression coping that has some lips on them, and it holds the gums in, and then we put a Copac dressing over top to help mold that lip and buccal tissue. Because that buccal tissue is going to want to encroach over. So here you can see that this is the implant over here. This is the componentry. Not visible on the scan is the fact that there's a small band of tissue wrapping around these implants. This buccal tissue is now being forced to attach right here, which creates this land area, this pseudo-neutral zone for our future restorations. Without creating this land area, this buccal tissue is going to come all the way over and create that wrapping around that inflammation and that ditching that we saw earlier for that lady. So on the 3D reconstruction, you can really see when we do we really bulk out the tissue out towards the facial, because we want to give the future restoration as much neutral zone, as much room as we can. And these are a couple of CTs taken on post-gum graft patients. I think if you ever want to evaluate the vestibular anatomy and the land area of your complex implant cases, this is just a puff cheek technique. So this is a plain old cone beam CT scan. The only thing is that you're asking the patient to puff out their cheeks while they're taking the CT scan. And what we're looking for in these post-gum graft cases is this tiny little black gap here, right? This is our land area. This is our proof that this buccal tissue now has a firm attachment, has a new mucogingival junction, if you will, right here, lateral to the implant, such that when the buccal soft tissue collapses, it does not collapse onto a restoration causing friction, and such that when the buccal tissue animates, it does not tug and pull and create a peri-implant gap that it is inviting infection. And one of the cases that I had the privilege of working with Caroline before she took a leave, was just that right over here would be that thin band of attached tissue around which Caroline had very nicely created some kind of a superstructure for us around these implants. This is that Copac dressing that was being removed about 3 weeks after surgery. And on a maxillary patient, things look a little bit different, but it's really the same principle. The last benefit that we derive from all of this is that there tends to be a lot of lip tethering. Remember, when the lip is sewn basically to the floor of mouth, this lip has very little mobility, so it interferes with speech and interferes with prosthesis design. We do know that this technique releases that lip. So there's both immediate gain of lip laxity, but also long-lasting gain of that lip laxity. So coming back to our original question of would you offer the husband and wife team the same day all-on-4 lower restoration that they are seeking, I can only speak personally from a surgical point of view. I would not hesitate to offer it to the gentleman on the left-hand side, but I may be conscious offering it to the lady on the right-hand side. And my concern is the amount of readily available attached tissue. Looking at the husband of this theoretical case, there's ample attached tissue here that I'm confident the immediately placed implant will have good tissue support circumferentially. Whereas for the missus, right over here would be where one of my implants would protrude. I worry that there's no attached tissue there whatsoever. Same thing with the first premolar here. Same thing with the first premolar here. So that would be my hesitation to offer this lady over here a same-day all-on-4 restoration. Because my worry is that if immediately placed, some of her implants may end up looking like this a year or two down the line. Now, am I advocating a drastic change to the all-on-4 workflow? Am I saying that all all-on-4s now need to have a secondary gum graft, after osseointegration? No, I think that would be ridiculous. I think that would defeat the entire immediacy and the entire workflow of the all-on-4 cases. But I do wonder for these kind of cases that have soft tissue challenges, what if we just did something very simple, right? What if this gentleman can get the immediately placed implant, and this lady unfortunately has to sacrifice maybe 6 weeks of temporization where we take the teeth out first? Because that's really all we need to do. There's no gum grafting that's needed. Once these teeth are removed, this entire zone of tissue becomes attached keratinized tissue. And then bisecting that thick band of attached tissue at the time of implant surgery 6 weeks later, we can still go on to place the implant in the socket. We can still go on to immediately load those 4 tilted implants. The only difference is that she had to wait 6 weeks, during which maybe she wears a temporary denture, maybe she wears nothing. So that sort of wraps up for our clinical portion. I think with a bit of time left, I would love to share with you my thoughts on case acceptance for these kind of complex, oftentimes interdisciplinary reconstruction cases. I think in general, we can say that there are 2 workflows in these kind of cases. Some of you in this forum have the blessings of having 2 skill sets. Some of you are able to offer both the surgical and the prosthodontic aspect of this care as a single clinician. And to you guys, I just bow down. I think it's amazing for one person to have 2 skill sets. It's not something that I don't think I can ever do. I think patients appreciate this workflow as well because they have a very direct source of answering their questions, right? They can come to you in your dental chair and you're capable of answering every single question on every aspect of the care in a single visit. And I can only imagine in that workflow, case acceptance is a very linear pathway. I can share with you my woes as a dual clinician model. Not always that smooth. I think even those of you who are single clinician capable in the audience, I'm sure there are cases for whatever referral reasons, you end up working in a dual clinician model. And I think we all share the same frustrations, right? Patient comes to see me, I answer all the surgical questions, they start asking me prosto questions, I had to say, I don't know. And I imagine similar things happen in your chair when they ask some surgical questions. And there's a lot of back and forth, there's a lot of half answers. Maybe the patients eventually get there to a case acceptance, maybe they don't, maybe they get exhausted. Maybe they will look elsewhere and find somewhere that can answer the questions a little bit more directly. So knowing that this isn't going anywhere, I don't think that dentistry is moving towards it's all become dual trained. The question then becomes, if this isn't going anywhere, is there a favored approach? Is it a prosto first or is it a surgical first? And what are the benefits? I think that if you were to follow just conventional dentistry wisdom, most of us would say, well, you should see the prosthodontist first, of course. The prosthodontist is the architect. They are the mastermind, the quarterback of any treatment, especially complicated treatment. And I think as a prosthodontist, if I was to ask you, okay, well then, what is your workflow? What is your workup? I'm sure it's a variation, but I'm sure it's something like this. Visit 1 may be more record gathering, maybe photos, mounted models. Maybe just a brief discussion, a cursory, get to know the patient. But visit 2 would be then the formal case presentation and a more detailed decision making. And in terms of what you discussed during these 2 visits, well, I think medical legally, if the patient is really a blank slate, a full arch is as blank slate as it gets in dentistry. Well, I guess it's kind of an onus to discuss everything, right? Maybe you focus more on one or the other, but really everything you see on this list, and probably a couple that I missed, are all potential options that we would want to offer this full arch patient who likely has low dental IQ, who likely will be overwhelmed by all of this, and just stares at you blankly after you talk about everything. And then to add insult to injury, what if then they go on to see the oral surgeon? And within 5-10 minutes of meeting either your periodontist or surgical colleague, several of these options that you spend all this time talking about end up being non-viable, right? Then what a waste of time that would have been, and what a additional source of unnecessary confusion to the patient to talk about things that were never really on the table for them in the first place. And you may be thinking, well, what scenario would there be for there to be something not on the table? Well, I'll show you some examples. So let's say here's somebody who just has been blessed with very, very generous sinus cavities. There's nothing wrong with them. That's the way they were born, and maybe there's some secondary pneumatization and super eruption due to non-opposition. But at the end of the day, they have very, very large sinuses. Are they then unable to seek a upper arch, full arch implant restoration? I don't think so. And I think if we could poll the audience to say, what would you do in this situation? I think many of us automatically think that, right? This is probably the definition, right? This is the reason of being of the all-on-4 treatment. And if you were to think this way and you think a little bit further, you say, well, this is probably not the occlusal plane that I want to restore to. Let's say that their central incisors in the maxilla are well positioned in their face. So let's say that that's our starting point. I want to recreate the occlusal plane that's a little bit better than current. That might be your occlusal plane. And say you're planning to extend your restoration maybe to a second bi or maybe to a small first molar, and let's say your restoration ends here. Well, if your alveolus is currently here, there's certainly insufficient room for your restoration. So some type of a alveolectomy is now necessary. And if you follow the path of the alveolectomy, it now carries you not just slightly touching the sinus, it basically takes you completely through the sinus cavity on both sides. Now, that's not a contraindication. There's no reason why we can't do this alveolectomy. But if I was doing this alveolectomy, I probably would want to repair a hole, the size bigger than a quarter. I probably want to put something more than just a membrane. I probably want to put some bone. And if I'm doing bone here and here, if I'm essentially doing sinus lifts, right? If I'm essentially doing bilateral large sinus lifts, is this your restoration of choice, right? I think that I certainly can't speak for prosthodontists, but maybe some prosthodontists I know would say, well, if you're going to go through trouble putting sinus lifts anyways, forget the tilted stuff. Just give me some axial implants at the molars, right? So I don't think this rules out anything per se, but it certainly favors one treatment approach more than the other based on surgical considerations that may not be readily visible during a routine initial prosthodontic visit. Similar pathology, or not pathology, similar anatomy, but different consequence. Another case of a large sinus, either sinuses that happen to encroach a bit more anteriorly to the central incisor area, right? So this is literally outline of the sinus cavity here and here. I don't think some kind of a all-on-2 is very viable. I don't think this is even implantable because of the nasopalatal foramen. But this certainly doesn't mean this patient can't have a full arch restoration. This patient would just go on to have massive sinus lift on both sides, and he would actually have excellent implantability throughout his entire maxilla. This is a person who obviously has already had some implant misadventures. But let's pretend that these are just a failing natural dentition for a second. In somebody with a failing natural dentition, and you say, well, the sinus looks a bit weird, looks a bit cloudy, let's get a CT scan. What you end up seeing is that it's not so much that their sinuses are cloudy, is that their sinus is in fact absent on their right-hand side. Silent sinus syndrome is a painless and symptomless atrophy of their maxillary sinus, believed to be due to chronic obstruction and inflammation. So I think any implantation in the first quadrant here would be somewhat complicated. Similar disease, silent sinus syndrome, but very different presentation. The sinus here atrophied up superiorly, but left a very normal looking alveolus down here. So even though they have a severe maxillary disease, really there's no impact to the reconstruction. And I'll show a couple more of these cases, and I'm gonna wrap up and make the point that I'm trying to make. This is a case of a very prominent alveolar antral artery. So facial to the maxillary sinus, where we usually make the osteotomy for a sinus lift, there happen to be some prominent arteries that can be present or absent in some patients. And let's just say that this was the case where you were looking for some sinus lift for whatever reason. Doesn't mean that surgery is impossible. It does make the surgery a little bit more complicated. Like in this case here, where you can see the vasculature a bit on the panoramic view, but you can see very clearly in the coronal view, there are not one or two, but there are actually 5 arteries along the wall of this maxillary sinus. So any attempt to enter the maxillary sinus will invariably rupture not one, but several of these arteries. And you may be thinking, well, but aren't you an oral surgeon? I mean, arteries shouldn't be that too much of a hazard. It doesn't look that big. It's not so much that the bleeding itself can be managed. This is not a blood loss, a patient instability concern, right? You can see that in clinically, the type of bleeding from this is definitely a little bit more than a little bit of oozing. There is a pulsatile, there is a certain volume and intensity to them. The fixer is really easy. The fixer probably just electrocautery with a little zap of electricity. You can stop this in about 5 seconds. The concern is that the collateral damage of the cautery. This artery is directly confluent. The the wall of the artery is also the wall of the sinus membrane, the Schneiderian membrane. So any cauterization of the artery will definitely fry your membrane. Not only is there a small tear at the area of the cautery, there's actually a zone of ischemia and sclerosis of all vessels nearby. So it kind of ruins the blood supply of your Schneiderian membrane, and to throw in a hole in it to boot. So it's not that these cases can't have sinus lifts, but if there is an alternative where we don't involve sinus lifts for these patients, they may have a better, more predictable outcome. Now, if you're interested in the ins and outs of an alveolar antero artery management, I'd invite you over to this reference. Again, it's not in the scope of our presentation today, but I want to propose something a little bit maybe off the beaten path. What if, right? What if we look to a view of saying the surgeon is actually the first person to meet these patients for these all-on-4 types of cases? In that scenario, well, what's the prosthodontic workup still? Well, yeah, there will probably still be a visit 1 and a visit 2, but it's going to look quite different. And I'll show you why that is in a second. Because this initial surgical visit almost becomes like a filter, right? We're going to filter out some of the patients that may be undesirable to be seen in your office. So if a patient can't afford total care, they really don't belong in your office. If there are certain modalities that are not really on the table for them, then we're filtering out the time that you would have spent talking to them about these non-viable modalities. Some patients just don't have the stomach for surgery, period. Some are dreaded red flag patients, and we'll end up flagging all of these scenarios for you if we see them first. And you would say, well, that sounds great, David, but why would my neighborhood oral surgeon want to be essentially my triage clinician? Like, why would they want to do that out of their own free goodwill? Well, it's not that big of an ask, if I'm being honest. For us, we're simple-minded people, so we think pretty simply. I think that with a cone beam and a patient sitting in front of us, 5 minutes is really all it takes to kind of rule in or rule out certain modalities. Remember, we're already seeing them. This is not an additional trip. They're in our chair, whether we do this additional step or not, because we're seeing them for a consultation, oftentimes for a full mouth clearance. And ultimately, no matter what kind of grandiose plans we have for this patient's implant reconstruction, we need you, right? We physically cannot render this care without the very necessary prosthodontic skills from you guys. So it's not like we have a choice of not seeing these patients. And I think the benefit of building this relationship with a routine surgeon that you work with is that you also end up capturing another referral source. I think because my wife is a prosthodontist, I may know the referral path a little bit of the difference between a prosthodontist and an oral surgeon who happen to practice in the same city. We both agree there are a group of general dentists who simply do not refer to a prosthodontist, period. I'm not saying it's good practice, but I think that's a reality of dentistry, that some dentists feel like they don't need to refer to a prosthodontist. However, all of those dentists invariably do refer to oral surgery for management of emergencies, infections, and sometimes extractions. So if you become that go-to prosthodontist for that particular surgeon, in effect, you've also captured the referral network of that oral surgeon as well. So I'll give you an example of what a typical workflow may look like for colleagues that I work with. So this is a staked letter for an imaginary patient, but it will usually look something like this. I'll see them for a full mouth extraction consult. In that talk, they talk about interest for full arch implant restorations. So in their planning software, I'll very crudely plan out some ready to go sites in green, saying we can put that implant in tomorrow if we wanted to. And I'll put in some achievable sites that say, we can't do them tomorrow, but they're very achievable with some grafting if that's the site of implantation that the prosthodontist is seeking. I give them a very, very short summary of the case. And I think for the receiving prosthodontist, getting this letter, looking at the screenshot, I mean, you may have some treatment planning ideas in your head already before you've even met this patient. And I think having this patient come with this letter to show up at your visit 1, that visit 1 would look very different than the visit 1 as you're just seeing a patient with no preparation at all. My last parting thought with you is that I want to talk to you about this concept of restoratively driven. I've been in dentistry maybe give or take close to 20 years if we round up. throughout that 20-year career, I think the words restoratively driven has been literally drilled into our heads. In fact, I opened a textbook and realized this is literally in the textbooks for the current generation of dental trainees. And I guess my thought is, does that apply to full arch implant cases? The type of implant that we're doing nowadays are dramatically different than back when the concept of restoratively driven was created maybe 20 odd years ago. In the short time that we have together, I showed you 6 different cases where surgery greatly dictated one direction versus the other in the design instead of the restorative concept. And we focus very briefly on one jaw, the maxilla. We focus very briefly on one anatomical structure, that is a sinus. Imagine how many other different scenarios there are where surgery really curtails the real options on the table for the patient. So I'm just wondering, I realize I'm in a room full of prosthodontists, and this is a dangerous territory. I'm just wondering, and the irony is not lost on me that as an oral surgeon, that, were the reasons that you guys came up with restoratively driven in the first place. Our spectacular implant placement back in the 90s is the reason that this concept even has to be a concept. But I'm just wondering, in the context of a full arch restoration, definitely still very much restoratively driven, but maybe thinking of it as a surgically limited first and foremost idea, maybe may change the way that you approach the planning steps of these cases in some capacity. I appreciate the time I've been given to share these thoughts with you, and I want to thank the organizers for the very kind invitation.
Thank you very much, Dr. Yang, for this presentation. I have to start by saying I find you very brave to suggest a bunch of prosthodontists start by having surgeons doing their initial consultation.
Internet adds a lot of bravery. I couldn't do this in real life, that's for sure.
It's an interesting concept. I certainly see it just because I've worked with you, and I appreciate the fact that we were basically having just you jump in because we were working in the same practice, which made things a lot easier for a lot of these conversations. So basically everything happened at the same time. So I can appreciate where you're coming from with this concept. I think it's going to take a little bit of time for us to let it sink in a bit more. A question from the audience that we have here is, for cases where you have a fibula, do you suggest doing the free gingival graft on top of the skin free flap, or do you remove part of the skin flap or in addition to?
Thank you for that question. I think that Dr. Nguyen can probably answer this question even better than I can, because we went through those early bumbling steps together. What we found when we attempted to do a free gingival graft on the fibula before implantation, the struggle with keeping that gingival flap well adapted to the bone, because a lot of times it would just lift. There's nothing holding it down, so the lift of the buccal and the lingual tissue completely lifts up this attached band of gingiva. Whereas with a peri-implant design, the implant can act as the anchor to hold everything down. So nowadays we only do it as a post-implant. Regarding the skin, we feel like the skin adds nothing, so we generally resect as much of the skin, hopefully all, whenever it's feasible to do so.
Thank you very much. I'm gonna let people, oh, there you go, one more question here. In some of your cases, what would be your first choice of prosthesis for long-term success and less complication? Would that be fixed or removable?
This is the moment where I was hoping I had a virtual background up, but I don't. Hey, buddy, I have a meeting. Would you mind giving me 5 more minutes? Thank you, buddy.
We are all used to working away from home now.
I think if it's a fibular patient, I think the Canadian healthcare system is a lot different than the American. I think budgetary constraints look for something that's cheapest with great longevity. We try to go removable whenever we can, right? So some kind of removable bar over denture or removable conus. Maybe we feel more comfortable leaving those guys in the community. versus say a fixed hybrid where we know they're going to have great difficulty maintaining cleanliness.
And how about your private practice cases? So not talking about necessarily cancer patients, but major reconstruction. I see Pamela in the back, I think.
It's the pros of having a large head. I never realized there was a pro until now. I think in the private practice setting, it's really up to the patient, right? You kind of read the patient. If you trust their hygiene and they want fixed, then you go fixed. If you don't trust their hygiene and you don't want to deal with headaches 3-5 years down the road, then you just be very persuasive in swaying them towards the removable pathway.
Perfect. Well, thank you very much, Dr. Yang. And thank you, everyone.